Welcome to the case study number 2. In this case study, we will talk about antiviral kinetic modeling and its role in drug development. Now shown here is an overarching strategy for viral kinetics, and this is a key component of model interconnectedness. So when a viral pathway is modeled, there are some key considerations for the virus, and this includes infectivity, virulence, and resistance. That in turn leads to the pharmacology module, where the key components are dose, regimen, POP-PK, exposure response, but also to an individual disease model that includes viral kinetics to symptoms and severity of symptoms. In addition to this, what is often not used frequently is the epidemiology and payer modules. These are two separate components of the modeling process that is rarely used in conjunction with the pharmacology modeling. And here you use multi-scale models and health economic analysis to support the infection rates within the community and what public policy decisions one would need to take to control that virus. There are several ways to develop a viral kinetic modeling. In general, there is if you think about it in simplistic terms, you have a group of cells, which are the epithelial cell, which gets infected at a rate of beta, and those cells become productive infected cells with a high capacity for infection using another rate constant K with a clearance rate constant of delta, but also the productive infected cells being converted back to the cycle to virions through other rate constants P. Now that's the viral cell cycle. Now superimpose that to the drug concentration versus inhibition of viral load, which is a viral kinetic PK/PD model. You can use the symptom score to bring in additional components. Now the simple PK part of the model is quite simple. You have the central compartment, but also the peripheral compartment, which could be lung and or nasal, and with clearance from the central compartment and intercompartmental kinetics. So collectively, this forms an opportunity to relate viral cell cycle kinetics with PK/PD, but also symptom scores. The structure of the antiviral inhibition model is therefore just an extension of the previous schema that I reflected on, except that now you have a drug component coming into play at the beta level, but also you have the drug component at the conversion of productive infected cells to the virions. And that's also connected with the distribution of the concentration in plasma and lung. Now, in terms of exposure response, there are a number of examples which is published in the literature. There's abundant data available for influenza as well as RSV, where you have exposure response in terms of nasal Cmax as a function of different dose and how much of it could yield productive concentrations of the drug in the matrix of interest, or the inhibition of P as a function of concentration, where you see an asymptotic concentrations leading to plateauing of the concentration at higher concentrations. The simulated viral load responses to adults is often done to optimize doses, and as you can see here, you have a viral load log plot as a function of time that goes from 24 hours to 216 hours. You have the LOQ line. The placebo is where you don't see an effect, but for different drug concentration yielding from different doses going from 2 milligram QD all the way to 200 milligram QD, you see a variety of changes to the viral load as a function of dose. And on the right-hand side, you see a percentage decrease in viral load AUC as a function of dose. And you can see that the curve maximizes at about 50 milligram when you get the peak effect. So the maximum viral load suppression predicted is approximately 50 milligram QD. And that's the similar dose indicated for reducing symptom development. Now that data is not shown in this plot. Now, the disease model for influenza can also be adapted to include cytokines and clinical data, which is what you see here. This is the same plot from before, but you have this additional compartmental components relating to the effect on IL-6 and CSS, and that leads to more mechanistic application of viral kinetic models. There is also an agent-based modeling approach, which is a bottoms-up computational modeling approach that focuses on the rules and interactions of the individual components of the system. Now, agents are defined as autonomous entities. They could be defined as properties, behaviors, or interactions. And agents can represent pretty much anything in the model: person, a building, a railroad car, virus, cache, etc. And agent-based modeling is very commonly applied in epidemiologic circumstances. Now, we have seen the PK model here. This is of importance: location and behavior. You have demographics as a component. You have the viral kinetic models here. So these two aspects are taken from before. The covariates obviously are important. Location is critical. For example, when you're dealing with COVID pandemic, you want to understand what are the areas where there could be higher localization of infected patients. Now, this is a simplistic plot. It shows a pandemic scenario with no treatment. You see the application of the ABM model, and this is a very good use of the value proposition of an antiviral, whether that's different with different public health policies to the actual patient level. Now, shown here is the oseltamivir dose and drug uptake on cost, life years, and quality adjusted life years data. In terms of two categories, there's a low virulence and low transmissibility, as well as a high virulence and high transmissibility. And depending upon the uptake scenarios, there are three scenarios: 25%, 50%, 80%, which is the same in both cases. And you can see the change in costs, whether to the payer, societal, change in death, life years, quality adjusted life years, etc., from both the payer perspective and the societal perspective. So such a table gives the decision for the payers as well as society to assess the controllability of the virus in terms of the information arising from the modeling outputs. And that's the example shown here in terms of the differences between the payer perspective and the societal perspective for the low virulence and low transmissibility scenario. And that's the similar table for the second scenario, which is the high virulence and high transmissibility. Now, which scenario gives you the most cost-effective solution? That's really the bottom line in terms of assessing controllability of virulence. So under these two scenarios, you have a low virulence scenario and a high virulence scenario. And there are several dosing options for oseltamivir, which is ranging from 75 milligram BID to 150 milligram BID. Now, such models are extremely complex and often less applied, but there are benefits of using a pharmacology to pair models. especially in the context of model-informed drug development. These are extremely complex systems connecting viral kinetics to PK, pharmacology, but also the ABM approach to agent-based analysis. Now, the MIDD of complex systems has primarily advanced vertically in many scientific domains. There are domain-specific approaches and applications, as we saw here for Tamiflu. This case study is an example of a multidisciplinary approach to MIDD and facilitates an immediate impact to public health policy. It affords effective communication and knowledge transfer to link domain-specific expertise. And there are several multidisciplinary approaches to address multiple stakeholder perspectives, offering a significant opportunity to expand and enhance the value and impact of MIDD within the global healthcare sector. So what is the state of the art? This is continuing to emphasize model interconnectedness, where you have the standard PBPK models, the PK model, PK-PD, the focus on mechanistic detail as a function of disease focus, and the evolution of the QSP disease platforms, but also more recent, more holistic model-based meta-analysis. But as we discussed here in this particular example, the use of pharmacology to pair models. Collectively, this represents interconnectedness of the model. Thank you for your attention.